Like there's some confusion about PIP, PEP. Like positive inspiratory pressure versus positive and expiratory pressure. So we'll go all over all that and some proper techniques for simple things like just even a shoulder roll. Okay, so let's get started. So you guys all know or not know? I mean, hopefully you do know completely the NRP algorithm, but you know it exists, and you can review it when you need to, and it's a good framework. So, common scenario, okay? We are having a cesarean in OR2. Can you please come? So do you have enough information to determine what you should set your FiO2 to? Do you have enough information to determine what size ET tube and the laryngoscope blade that the Neo is going to need? What other equipment might you need? Do you have enough information to determine that? Anybody? Anybody tell me? Chat's fine too.
Well, you need to know, you got to know the gestational age. That helps with the ET tube and the laryngoscope blade. You need to make sure you have your PPV equipment available and pulse oximetry. And FiO2, isn't that 21%?
It's usually 21%, but for a preterm infant, it can be, you can set it at 30 if you'd like. So no, you do not have enough info. You're correct.
Yeah.
Okay. So what questions should you ask before every birth? What is, like Lacey said, what is the expected gestational age? Is the amniotic fluid clear? Are there any additional risk factors? Mom preeclamptic, is there chorea? Is it a poor tracing? Umbilical cord management plan, all this, we discussed that with the OBs. But those first three questions are, it's information that's easy to communicate quickly on the phone call to the provider. So it turns out, no, it's not a term infant. It's a 30-week infant with a history of IUGR. The person who relayed the information by phone did not know all this. There is meconium stain fluid. Okay, so very different from a term delivery. Okay, so do you have everything you need? Well, everything, because we didn't know, we didn't set everything up and didn't have the proper ET tube size. So you need a 3.0 ET tube, maybe a 2.5, depending how small this kid is. A 0 Miller blade, maybe a 00, depending on how small this kid is. FiO2 set to 21 to 30%, but I usually start at 30% for a kid like that. Okay, a preemie mask for your neopuff or self-inflating bag. Okay, so just with those three questions that are, they could be one-word answers. We could have had all this stuff ready. We also may need a transwarming mattress and a polyethylene bag. Right. So with the first three questions, that information could be relayed in 5 seconds. We could have had all this stuff ready for resuscitation. And, what if this kid needs a major resuscitation? What if this kid needs intubation, chest compressions, epinephrine? Based on the gestational age information there, IUGR, we can, I can, in my head, as I'm walking down, figure out what epinephrine doses I want for IV or endotracheal, okay? What amount of normal saline bolus do I want? I can already have that in my head as I'm walking down into the OR to be at this delivery, okay? Any questions about that? So this paper is a really nice little review about what anticipatory information and stuff and anticipatory activities that you can do to prepare for delivery room resuscitation. These author names you may see on like NRP steering committee stuff. And one quote out of this paper that is really the biggest part of why I'm doing this is a Sentinel event alert from the Joint Commission reported a study of infant death and major injury during delivery, finding that the most common, 72%, identified root causes were related to communication issues. Okay, I think this is a theme for a lot of reasons why there is morbidity and mortality, communication issues, and in my prenatal lab PowerPoint also, the identified cause of major injury in a baby with regard to prenatal labs is communication. Okay, so take this with you. Take this information with you. Communication is key in anything you do. Anything, hand off on any patient. Okay. This is a pre-delivery checklist in the NRP book that you guys can review. Okay, this is a nice little guide um, to all the information, all the equipment needs that a neonatologist may need. Okay, to refer to this. Common scenario number 2. 39-week mom in labor, benign pregnancy, category 1 tracing throughout time in the hospital. There's clear fluid, fetal heart rate dips suddenly when pushing. There is a cord around the body, and the infant is delivered stunned, apneic with low tone, and is cyanotic. NICU doc and NRN are another delivery with thick meconium and actively resuscitating that infant. One of your colleagues is trying to reach the NICU charge nurse to come down. What are your steps? If anybody wants to, in the chat or any audio is either is fine. So you've already called for help, right? So that's one checkbox. All right, I understand, right? So usually first cry happens within 30 seconds, okay? If it doesn't happen by 30 seconds, cleanse the cord, bring to the warmer, okay? If this baby is delivered like really limp and really cyanotic such that you don't believe that this kid is going to respond to tactile stim, then let the cord, bring to the warmer immediately, okay? And so within 30 seconds after birth, approximately 85% of term newborns will begin breathing, okay? An additional 10% begin breathing in response to drying and stimulation. To successfully transition, approximately 5% of term newborns need positive pressure ventilation, okay, 5 in 100. 2% of term newborns need intubation. 1 to 3 per thousand need CPR or emergency medications, okay? So 1 to 3 in 1,000. So we have 3,000 deliveries, so something like 3 to 9 per year, major resuscitation, okay? So it's not a small number, okay? If you work full time, you will see a couple, hopefully. So you perform some brief tactile stimulation while the cord is intact. The infant is still apneic, cyanotic, with low tone. What next? Clamp the cord and bring the kid to the warmer. Cord is cut. Bring the infant to the warmer at 30 seconds of life. What is your next step? You already done tactile stim, so I would do positive pressure ventilation at this point. Okay. What are the indications? That's right, Paula. PPV. Yep. What are the indications for positive pressure ventilation? So if the baby is not breathing or apneic, if the baby is gasping, or if the baby's heart rate is less than 100. And if indicated, PPV should be started within 1 minute of birth. So that should be your goal, okay? Ventilation of the newborn's lungs is the single most important and effective step in neonatal resuscitation. Everybody gets worried about intubation, chest compressions, and medications, but this is the most important step. So if you can do this, then you are ready, okay? Or you have something in your bag. You have something in your tool bag, okay? Mask size is important, okay? So oftentimes, just like in that first scenario that I talked about, we'll have the wrong size mask. And for a kid who's an IUGR, that it's going to be really important because the term mask is going to cover that entire kid's face. So you want what's on the far left, okay? Around the bridge of the nose, good seal around the bridge of the nose and chin, nothing like the next three where you don't get an appropriate seal. So you're not going to be able to get that positive end expiratory pressure or positive inspiratory pressure if there's a leak around the mask, okay? It should not be covering the kid's eyes. It should be covering both the nose and the mouth in that left picture like that, okay, with a good seal, okay? What are the initial settings that you need to set the Neopuff to? So greater than 35 weeks gestation, 21%. That's preemie, 21 to 30. I usually start with 30. The flow to the machine, the flow to the Neopuff is 10 liters per minute. Okay, that's how the Neopuff gets its supply of pressure and air and oxygen. Okay. Um, when you're breathing, when you're doing PPV, aim for 1 breath a second, 40 to 60 breaths a minute, 1 breath a second. Okay. You can begin your PIP at 20 and your positive and expiratory pressure, your PEEP, at 5. Okay. NRP now says you can go up by 5 centimeters per, like when you do your Mr. SOPA, and we'll talk about that. We'll talk about it in a little bit. Okay, so what are these things? What is PIP? What is PEEP? So PIP is your positive inspiratory pressure. It is the peak inflation when you are ventilating a baby. Okay, so it's your breath. Okay, and on this graph, as you can see, it's a higher pressure, right? 4 times greater than the PEEP. What is your positive and your PEEP, or positive and expiratory pressure? It's the minimum. So we generate our own PEEP. Okay, so we are with our diaphragm and our negative pressure in our thorax, we open our own alveoli and create a pressure different than the atmospheric pressure, right? Like a preemie can't do that, right? A preemie has poor compliance, cannot, like their respiratory muscles are undeveloped or not as strong, their alveoli are more stiff. Even in a term infant with fluid in their lungs, right, the compliance is less, right? So they are less able to generate PEEP by themselves. So when we are ventilating for a baby, we do that extrinsically with our Neopuff to keep the alveoli open, because when those alveoli collapse, it's really hard to get them open, right? So the PEEP is like your baseline. It's your baseline inflationary pressure that you always have in your lungs when you're not taking a breath. When you do take a breath, or when we give a breath, that's positive and expiratory pressure. Okay. And the time at which you occlude the Neopuff is the inspiratory time. Okay. So any questions about this? So I've heard that there is some confusion. There needs to be, you needed a little clarity about this. Is there, what specifically is confusing about this, if anything? I think everybody gets it, right? So PEEP, it's your baseline pressure of your lungs when you're not even breathing. Okay, when you're not taking a breath. Positive inspiratory pressure is taking a breath, or giving a breath with the Neopuffer bag. All right. Okay. All right. You provide PPV with Neopuff for 30 seconds. There is no chest rise, and your colleague auscultates a heart rate of 80. Pulse oximeter is placed preductally on the right hand and shows 60% at now 1.5 minutes of life. You increase the FiO2 to 100%, anticipating a major resuscitation. What next? What would anybody do next? I gave a clue already. I already said it. Mr. SOPA, that's right. So the A part is my responsibility. But the first 5 things you guys can do. So mask, reposition the mask, reposition the child into the sniffing position. Suction the mouth, or gastric suction in the nares. Open the mouth slightly, and you can increase the pressure. You can increase the PIP more, okay? Positive inspiratory pressure more. You can do increments of 5 to up to 30 or 40. So 40 for a term, 30 for a preterm, okay? What is Mr. SOPA? Mask readjustment. So reapply the mask, lift the jaw forward, consider holding with 2 hands. Reposition the head and neck into the sniffing position. I'll have a picture of that. Okay. So the head has to be neutral, not hyperextended or flexed. Suction the mouth and nose. Use a bulb suctioner or suction catheter. Open the mouth with your fingers slightly, or increase the pressure, as I said. So actually, it says 5. You can increase in increments of 5 to 10. 10, that's a little scary for me. because I don't want, you don't want to cause a pneumo. And actually, last time I did this during the resuscitation with a kid with meconium, when I just increased it by 5, the kid had a small pneumo. So in training, I was honestly taught like 2 to 4 centimeters increments, centimeters of water increments. So, but NRP does say you can increase by 5 to 10. And then, a pneumo is something that is correctable. Hypoxic brain injury is not. So you do what you got to do, right? Alternative airway, that's my job, right? So unless we have LMAs, those are things that are relatively easy to place. But A is usually my job, right? Any questions about Mr. SOPA? All these things can be done instantaneously, right? Especially the first 2, repositioning and O. All right, so correct sniffing position. So the roll is supposed to be under the shoulders, okay, not under the neck. It's supposed to be under the shoulders. I do find that the roll, I mean, the baby is kind of slipping forward when I get there, and bad timing, but I do see neck rolls a lot, and I do hear about it referred to as neck rolls, but it's a shoulder roll. Okay, so the optimal position is the baby should be facing, looking at the ceiling if the surface was flat. So the infant should be looking at the ceiling. All right. Why is this? Well, if you're hyperextended, the airway isn't in an optimal position. Same thing as if the infant is flexed like that. Okay, chin to chest. If you guys put your chin to your chest, you feel it's a little bit harder to breathe, right? For an infant, especially a preterm infant, it's a lot harder to breathe. Okay. Any questions about the sniffing position and shoulder roll? Cool. All right. In terms of suctioning, these are the types of suctioning you can do. The nasal passage. If you're orally suctioning, you're kind of getting the back of that the oral pharynx there, or actually, sorry, here, and then pharyngeal, or again the back of the oral pharynx there, and then deep suctioning, getting that catheter down there. And make sure you guys know how to do all those things. So common scenario number 2. Infant is now spontaneously breathing with a heart rate greater than 100. Infant's breathing is still labored with visible retractions, nasal flaring, and tachypnea. So breathing spontaneously and heart rate above 100. What do? You're still giving PPV. You stop PPV, right? And then what do you do? What do you do? The kid's still labored. CPAP, that's right. Good job, Veronica. Thank you. And Paula. Yes, CPAP. So what is the proper way of giving CPAP? And check the pulse oximeter, yes. So is this person delivering proper CPAP? What is this person doing? No, that's right. No. Person is giving positive. This person actually is giving CPAP of 20, right? Not delivering proper CPAP. Yes. Hopefully this kid doesn't have a pneumo. Hopefully this mannequin doesn't have a pneumo. Okay. So this person is giving positive inspiratory pressure. Okay. PIP part. Okay. What about this? Correct, right? This is absolutely correct. This person is delivering a proper CPAP. Now the mask is too big for this mannequin, covering the eyes, but we can, don't have to nitpick that. So this is proper CPAP, not including the PIP. Okay. Infant is now breathing spontaneously with 100 heart rate greater than 100. Infant's breathing is labored with visible retractions and firing into me. So CPAP is the right course of action. Infant is saturating 70% at 4 minutes of life. Is this appropriate? I think it's just below what we want. We want 75 to 85 at this point, right? Or 75 to 80. This is your this is posted at every I think every panda warmer in L&D, so that we're able to titrate our FiO2. Okay, and by 10 minutes of life should be 85 to 95. Okay, it's also on the NRP algorithm. Okay, and that CPAP part is on the right. All right, labored breathing or cyanosis. Okay, so we're going to take a different path. We're going to take a different path here. So the baby, the baby didn't recover. So the PPV isn't improving heart rate. It's still less than 60. And you have done MRSOP. What is next? Alternative airway, right? So that's my job. All right. So as we alluded to earlier, we do need to know the gestational age and/or weight to determine what size equipment we need. So below 28 weeks or below 1 kilo, we'll need a 2.5. Lacey, it's actually recommended to get an airway first for compressions. Although, I mean, if I'm not there, if I'm busy in another resuscitation, like that first scenario, then that would be warranted. If you've done your MRSOP part, but it's recommended to get an airway first, if you can. So 28 to 34 weeks or 1 to 2 kilos, a 3 endotracheal tube, and greater than 34 weeks, a 3.5 or greater than 2 kilos. And the pictures at the bottom right corner are important in terms of setting up the endotracheal tube. Make sure the stylet, I think most of the neos here like to use stylets. So make sure the stylet is not protruding past the end of the endotracheal tube, because if it is, it can cause a tracheal perforation. Okay. Make sure it is before even those side holes. Okay. Another thing you need to do if you're anticipating a major resuscitation, cardiac monitor, right? So set up your leads, light on right, smoke over fire. Okay. So I show up, I intubate, and there is appropriate color change on the PD cap. There is mist in the ET tube. Breath sounds are equal on auscultation, and there is adequate chest rise, but the heart rate is less than 60. What now? So I know I have adequate ventilation because the chest is rising and all the other factors. Now you do chest compressions, right? Get it ready for line 2. Yeah, if there's enough people. Yeah, if get ready for line. Somebody's got somebody do chest compression. Somebody get stuff ready for line placement. Absolutely. Okay. So what is the adequate or the appropriate place to do chest compressions? That lower third, lower third of the infant sternum, right above the xiphoid process. Okay. And what is the depth? If anybody can write in the chat what the appropriate depth is. Two-thirds a lot. That's a lot. It's 1/3. 1/3 AP diameter you want. Okay. Two thumb technique, 1/3 AP diameter, and you're not going to be able to get down to 2/3 anyway, unless so 1/3 AP diameter. Okay. And in the best circumstances that the person doing the chest compressions goes to the head of the bed, because that's a much more comfortable place for that person, and the airway person goes to the side, and then that allows the last side for line placement. Okay. 1/3 AP diameter. And do not lift your thumbs off the chest when you're doing it between compressions. Okay, keep in contact with the infant. The way you do chest compressions and breathing synchronously. Okay, so it's good to say this out. It's not good enough to just think it in your head. It is good for the person, like the person running the code should start this off, okay, and then eventually move to the point where they're doing lines. But the airway and circulation people should be doing this out loud. Okay, 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. Okay, so 1 and 2 and 3 compressions and breathe. All right. So saying it out loud. So say it in your head often. Maybe when there's a impending major resuscitation coming up, run it in your head. 1 and 2 and 3 and breathe. Okay, so you're not thinking about that when the time comes. Okay. Learn the code. Please say this out loud. It helps. It really does. Is there anything else? Did anyone document? So documenting is important, especially. So we had that full code the other day, and where all you guys that were doing the documenting, it helped so much. I think Paula, you one of the people document, and Rachel too, Rachel Rudick, Abrams. So documenting is important. The medical stuff is the first thing that needs to be done, but if somebody could get it all down on paper, it's extremely helpful and extremely important. Okay. I think that's all I've got. So I intend to eventually do add on an advanced review to this. I haven't had the opportunity to yet. It's all going to be exactly stuff from the NRP book as above. But I figured I'd start with this and clear all that stuff up first. Was this helpful? Cool. So I guess I'll get you guys a quiz, like a small 5-question quiz, like within the next week or so. Yeah, hopefully this helped, and maybe I should do this. Like this should be in the rotation, especially when we get a lot of new folks. So yeah, really, I got most of my stuff, most of the slides from the NRP book. That paper that I referenced, that's a good read. It doesn't just talk about like the resuscitation itself. It talks about anticipatory stuff for the mom, and other things about preparation things and communication and positioning in the delivery room. And it has a lot of debriefing stuff too, like effective ways to debrief. So that's a good read, that paper.
Dr. Lee, I have a question. At what point would we just provide blow-by to an infant?
Oh, when they're not labored and the SATs are still kind of. I mean, you have the choice of doing either. So you could do CPAP if you would like, if the kid's not labored breathing, but has a less than target SAT. So you have the choice of either blow-by or CPAP in that instance. I usually just do CPAP because you know what's happening. It's retained fetal fluid, and the alveoli are struggling to open. And the fluid needs to be cleared. So I usually do CPAP. I rarely do blow-by. But if the kid is not having labored breathing and is not meeting SAT goals, then blow-by. I should include that, like proper ways to do blow-by. You can't do it with a self-inflating bag that doesn't have a reservoir. You can't do it with the ventilation side of the self-inflating bag. So yeah, I should add that. Thank you for that.
I had a question too. It's Paula. If the baby is just labored or, labored breathing, or, we notice retractions and flaring, and we call for, you guys to come and assess the baby, would it be appropriate to do CPAP?
If are we talking like an hour after or?
Yeah, 20, 30 minutes after we notice the baby is having trouble breathing. Labor.
I mean,
breathing.
I think that you do the other stuff that, like chest PT and suctioning and stuff. And if the kid is still labored, then, I think it's better if you call us, and then we do the CPAP. Yeah, I think that would be the better course of action. So do the stuff that is easy to do, chest PT, suctioning, things like that. But if the kid is like extremely labored, I think I'd rather get the call first. And you can start with the chest PT and stuff as we're walking down there.
Yeah, I know it does happen quite. Yeah, Lacey said it happened yesterday. It happens quite a bit, I feel like. And then while we're waiting, it's, we get different things on what we should be doing. And obviously we're going to be doing things to try and improve it, but I just wanted to clarify.
Certainly it's a difficult judgment call, right? So if it's a mild labor, I think a lot of people get a little freaked out, even if it's just slightly mildly labored breathing. In that case, do things to do that are easy, that have, or that are relatively benign, right? Your chest PT and your suctioning, and skin to skin. If this is after skin to skin, the kid's majorly labored, do the things you can. Yeah, again, if you've already done all this stuff, then call us. The more information, the better, right? So put a pulse oximeter on. If the kid is desatting and labored, and it's been an hour, and it's after skin to skin, after chest PT, after suctioning, then that's serious. That gives me my answer. But if it's simply a kid who is mildly labored, none of the stuff has happened. No chest PT, no skin to skin has happened yet. And the kid is pink. I think you give that kid a chance, right? But the more information, the better. Hopefully that makes sense. You're welcome. Hopefully this. I enjoy doing this, so we'll continue to make this regular. And if there's any feedback in terms of what you like, for example, what like the blow by part, if there's stuff that you want to hear about that I didn't include, this is my first time doing this PowerPoint, so I'll take any feedback to add stuff or. You're welcome.
Thank you again, Dr. Lee, for your time and always your expertise. For those that are attending from home, please feel free to write out an exception form and then hand that into our lovely Natalie. So thanks again, Dr. Lee. This was wonderful. And we look forward to your next session.
Excellent. Happy Thanksgiving, right? That's soon.
Thanks.